Hello, and welcome to Preventing Fraud and Abuse in Mental Health, Developmental Disability, and Substance Abuse Services. We are trying out this new method of delivering trainings via the web. It was requested by the Provider Council that we have more web-based trainings due to the difficulty with having a staff out for several hours during the day. We are open to any feedback on the process. The training objectives for today's training are to understand the cost and consequences of fraud, define fraud and abuse, know examples of healthcare fraud and abuse, know the governing statutes for fraud and abuse, know strategies for preventing fraud and abuse, and know how to report fraud and abuse. Here are some statistics and facts that help us to understand the enormity of the problem of fraud and abuse. The U.S. spends over $3 trillion per year on health care. We lose $60 to $68 billion of this money to fraud. This loss is huge and can be compared with the gross national product of Portugal, among other countries. Some estimates say 10 cents of every dollar spent on health care goes to paying for fraudulent health care claims. The $68 million lost to fraud is causing our health insurance premiums and out-of-pocket expenses to be higher and reducing the benefits our employers are able to offer us. The FBI Director, Louis Freeh, testified that the cocaine traffickers in New York and California were switching to health care fraud because it was easier, less risky, and more lucrative. Whistleblowers were paid over $307 million for helping to catch the offenders who commit these crimes, due to the laws we will discuss later in this presentation. The problem and cost of fraud is huge, and it affects everyone. We will begin our discussion of fraud and abuse by defining fraud and abuse. Healthcare fraud is an intentional misrepresentation, deception, or intentional act of deceit for the purpose of receiving greater reimbursement. Healthcare abuse is reckless disregard or conduct that goes against and is inconsistent with acceptable business and/or medical practices, resulting in greater reimbursement. Please notice the use of intentional and reckless disregard. These are important elements in defining fraud and abuse. Examples of healthcare fraud and abuse. For providers, examples include billing for services that did not take place, billing for the same service at the same time, called duplicate billing, misrepresenting a service provided, for example, providing targeted case management but billing for outpatient service, upcoding billing for a service that was more involved than what truly took place, billing for a service that was not authorized, billing for a service that is not medically necessary. Kickbacks are money given for referrals, and we'll talk about the anti-kickback legislation in a little bit. Identity theft or misuse of provider numbers. A provider's credentials are not accurate. Concealing ownership in a related company, and again there's legislation that we will talk about that's related to that. Consumers receive the same service regardless of need or medical necessity. Some examples of healthcare fraud and abuse in regard to members or recipients of Medicaid, Medicare, and other insurances includes using a Medicaid card that does not belong to that person, forging a prescription, using multiple Medicaid ID cards, reselling items provided by the Medicaid program, for example, medication, doctor shopping, which is visiting several doctors and pharmacies to obtain multiple prescriptions. An individual does not report all income when applying for Medicaid, and an individual does not report other insurance when applying for Medicaid. The next topic we will discuss is what factors are involved that contribute most to people's decision to commit fraud. We call this the fraud triangle, because the factors that lead to fraud involve opportunity, rationalization, and pressure. Pressure is the main cause that contributes to someone committing fraud. The pressure can come from a variety of situations, such as financial hardships, social pressure, and addiction, which can create a need or want. There is an element of secrecy to this pressure, as those who commit fraud have usually not shared their problem with others or dealt with it in more conventional ways. Some fraud is purely out of need to be self-indulgent. Next, we will talk about opportunity. Opportunity is the leg of the triangle that gives the person the ability to commit fraud. Most commit fraud because they believe the chances are good that they will not be caught. The ability to commit fraud in companies is set up under systems with poor internal controls, poor management oversight, or because a person in authority can use their position of power to gain access. This is the element that companies have the most control over. With policies, procedures, and mechanisms in place, companies can reduce the chance of fraud taking place. Lastly, rationalization is the critical factor in a person following through with a fraudulent activity. It involves the offender finding a way in their own mind to justify their behavior. Some common rationalizations are, I didn't know it was against the law. I made a mistake. My boss told me to do it. I just wanted to help the clients. It wasn't hurting anyone. Other providers are doing it too. I deserved it. The money won't be missed. So, what? I don't see why everyone is so upset. No one would have known. I didn't take that much. I was confused. They aren't clear about how to bill. Just a little humor for a very serious subject. What if I did doctor the documents? I'm a doctor. Next, we will discuss the essential legislation that has been developed to address fraud, waste, and abuse. The governing statutes are the Deficit Reduction Act of 2005, the Federal False Claims Act, the North Carolina False Claims Act, the Anti-Kickback Statute, the Stark Law or Physician Self-Referral, and HIPAA. The first statute we will discuss is the Deficit Reduction Act of 2005. The Deficit Reduction Act of 2005, as an act of Congress, became law in 2006. The Act contains provisions that pertain to fraud and abuse of Medicaid and Medicare. Provisions of the law established the Medicaid Integrity Program, or MIP, a federal and state program designed to monitor Medicaid fraud and abuse through the use of contractors to review and audit provider claims and activities, also to educate and support state efforts to reduce fraud and abuse. Every 5 years, the Comprehensive Medicaid Integrity Plan is developed by the MIP. Section 6032 of the Act says that North Carolina Department of Health and Human Services now requires each provider to sign a Medicaid letter of attestation when enrolling to provide a mental health, developmental disability, or substance abuse Medicaid service in North Carolina. This letter of attestation says that if you receive at least $5 million in Medicaid state dollars, that you must establish written policies on fraud, abuse, and waste, include detailed information regarding the company's policies around detecting and preventing fraud, abuse, and waste, and whistleblower protections. We'll talk more about whistleblower protections when we discuss specific North Carolina laws. Also, that it may include discussion of the fraud, abuse, and waste laws in the Employee Handbook, and this is in Federal False Claims Act as well as the North Carolina False Claims Act. Section 6031, this section offers incentives to states who increase their penalties and recover funding as a result of uncovered Medicaid false claims. The federal government will give somewhere in the range of 10 to 15% of the recovery back to the state. Next, we will discuss the Federal False Claims Act. The Federal False Claims Act, or the Lincoln Law, sets up penalties for people and companies that try to defraud government programs. Its origins reach as far back as the Civil War. In 1863, Congress passed the original False Claims Act when contractors sold the Union armies decrepit horses and mules, faulty rifles and ammunition, and rancid rations. The law has changed the landscape of corporate culture from one of deceit to companies paying lots of money for compliance programs. It includes a qui tam provision in which citizens not affiliated with the government can act in the best interest of the government and sue offenders. Offenders found guilty pay 3 times the damages plus civil penalties of $5,500 to $11,000 per false claim. The term qui tam is from a Latin phrase which means who sues on behalf of the state as well as for himself. The Act establishes liability when any person or entity improperly receives from or avoids payment to the federal government. Tax fraud is excluded from this law. The Act prohibits knowingly presenting or causing to be presented a false claim for payment or approval, knowingly making, using, or causing to be made or used a false record or statement material to a false or fraudulent claim, conspiring to commit any violation of the False Claims Act, falsely certifying the type or amount of property to be used by the government. In addition, the Act prohibits certifying receipt of property on a document without completely knowing that the information is true, knowingly buying government property from an unauthorized officer of the government, and knowingly making, using, or causing to be made or used a false record to avoid or decrease an obligation to pay or transmit property to the government. Next, we will discuss legislation that's specific to North Carolina, the North Carolina False Claim Act, also known as the Medical Assistance False Claim Act. Prompted by the Federal False Claim Act, North Carolina passed a similar law effective January 1, 2010. It was designed to deter persons from knowingly causing or assisting in causing the state to pay claims that are false or fraudulent. It applies to Medicaid as well as any other services funded by the state of North Carolina. To be eligible for the 10 to 15% of false claim recovery money, the North Carolina State False Claims Act has to establish liability for false claims, similar to the Federal False Claims Act that we've discussed earlier, establish protection for employee whistleblowers, and set up qui tam amounts similar to the Federal False Claims Act. And 3, to establish the circumstances that allow the state attorney general to prosecute the case. The case should be, quote, under seal, which has a longer statute of limitations and little room for negotiation. The North Carolina False Claim Act whistleblower protections. This part of the legislation cautions agencies that if an employee testifies or assists in an investigation of unlawful acts by the agency, they may not demote, discharge, suspend, harass, threaten, or discriminate against them. The consequences for these actions are that the company has to pay any damages to the employee, including any incurred being represented by the court. They must reinstate them to the same level of seniority and pay 2 times the amount of back pay due to them. The law says that North Carolina Medicaid providers are forbidden from knowingly submitting a false or fraudulent claim for payment or approval to the medical assistance program, or causing such a claim to be submitted, or knowingly making or using a false record or statement to secure payment from the medical assistance program for a false or fraudulent claim, or causing such a false record or statement to be made or used. The North Carolina False Claims Act specifically states that a provider acts knowingly when that provider 1. Has actual knowledge of the information, 2. Deliberately ignores the truth or falsity of the information, or 3. Recklessly disregards the truth or falsity of the information. A provider who has violated the North Carolina False Claims Act may be liable for a civil money penalty of up to $11,000 plus 3 times the amount of damages sustained by the medical assistance program for each false claim that was submitted. The provider will also be liable for investigatory and court costs, as well as interest on the damages amount. Lawsuits brought pursuant to the North Carolina False Claims Act can only be instituted by the North Carolina Attorney General. Thus, unlike the Federal False Claims Act, private citizens may not file actions against providers under the North Carolina False Claims Act. They must be represented by the Attorney General's office. Next, we will talk about the Anti-Kickback Statute and the Stark Law. The Anti-Kickback Statute. The first provisions in the Anti-Kickback Statute were added to the Social Security Act amendments in 1972. This act makes it a felony for individuals or entities to knowingly and willfully receive, in exchange for referrals, any money, gifts, or other gratuities when they involve a federally funded health care program. The elements that must be present include intention, direct or indirect payment, and the gift persuades the person to make a referral of payments or business to the gift giver. Some of the actions in the anti-kickback law have traditionally been acceptable practices in business and have created a lot of confusion over the years. There are some safe harbor exclusions to the law that have been added over the past few years. Please see Safe Harbor under 42 CFR 1001.952 for more details on exclusions. The Stark Law. This law prohibits physicians who bill Medicaid and Medicare to refer to a service that they have a financial investment in and for that referral to result in a claim. For example, the physician refers a patient to an agency in which they or an immediate family member has a financial relationship with that agency. Financial relationship is defined as an indirect or direct ownership investment interest in an entity through equity, debt, or other means, or a direct or indirect compensation arrangement with an entity. If violated, they must pay back the money and other penalties may apply. Health Insurance Portability and Accountability Act. Health Insurance Portability and Accountability Act, or HIPAA, was passed in Congress in 1996 and was created to improve the efficiency and effectiveness of the U.S. healthcare system. The main provisions of the HIPAA Act are access to medical records, notice of privacy practices, limits on the use of personal health information, prohibition on marketing, and that includes data warehouses that market to patients who utilize services, stronger state laws, confidential communications, and complaints. In addition, this Act clearly defines the meaning of fraud and abuse regulation programs and sets down the financial and legal consequences for non-compliance of the fraud and abuse laws. When HIPAA was first passed in '96, the focus was on the portability. Health care plans are accessible, portable, and renewable aspects of the law. This has changed significantly in the past few years to a focus on the accountability portion of the Act. The reason for this shift in focus is due to the egregious fraud and abuse of health care that has been discovered in recent years. In the recent implementation update number 90 on the Division of Mental Health, Developmental Disabilities, Substance Abuse Services website, it states, recently one provider who received a federal indictment operated an after-school tutorial program. Michael Sean Brown, a Columbus County school counselor and an outpatient mental health provider, licensed as a professional counselor, has been indicted on charges of wire fraud, identity theft, and arson by the U.S. Attorney's Office. He allegedly provided free teacher-supervised tutoring services, snacks, and transportation to children of lower-income families. Mr. Brown allegedly had his employees obtain copies of each recipient's Medicaid card. He is suspected of submitting false claims for therapy sessions to his billing agent in Florida for reimbursement from the North Carolina Medicaid program. Mr. Brown's business also burned down one night before he was scheduled to meet with investigators. Currently, Mr. Brown is charged with 20 counts of wire fraud, 2 counts of aggravated identity theft, 2 counts of arson, and 1 count of making material false statements. The implementation update goes on to say that providers should know that defrauding the North Carolina Medicaid program is a serious offense and will be dealt with accordingly. Sometimes the penalty includes civil and/or criminal remedies. Some common examples of fraud in mental health, developmental disability, and substance abuse service work include getting an MD or consumer to sign a blank person-centered plan. Someone else does the service, but a credentialed person signs for them. Not writing a note, but billing for it anyway. Working with 2 family members at the same time and billing for both separately. Rounding up your time with an individual instead of billing for the exact time. Maintaining a consumer in a service that is no longer appropriate just to keep them within the agency. Agency does not have the service they need. Providing services to a parent who doesn't have insurance but using the child's card. Exception would be certain services such as intensive in-home where family work is part of the service. Billing for services that don't meet the service definition description of billable services for the service. Not maintaining staffing required by the service definition. Using canned notes by copying and pasting from a previous note to a current note and just changing the date. Next, we will talk about some strategies to help prevent fraud and abuse. In this section of prevention strategies, we will discuss code of ethics, staff training and understanding, staff commitment to working against fraud and abuse, DMA program integrity, pre- and post-billing audits, self-audits, quality management projects, and agency risk assessments. Company Code of Ethics. It's important that each employee be familiar with their company code of ethics, also referred to as Code of Conduct. This is commonly found in your company's Policy and Procedures Manual. Field of Practice Code of Ethics. Many fields of practice commonly have a Code of Ethics as well. Generally, you can find the Code of Ethics for your field on your Board of Practice website. Here are some of the board websites for various disciplines. Staff training and understanding. As we mentioned before, the fraud and abuse laws require providers who bill $5 million or more Medicaid dollars each year to follow certain guidelines. However, all companies should work to train their staff on the agency's fraud prevention strategies, the company's fraud detection efforts, whistleblower protections, and fraud and abuse laws. Staff should also be aware of the statewide audits and what they entail. Staff commitment to working against fraud and abuse. Companies should get their staff to commit to working against fraud and abuse by helping them to understand the big picture. Healthcare fraud affects higher premiums and out-of-pocket expenses and reduced benefits for all consumers of healthcare insurance, including them. Clearly define and encourage pride in the company and its ethics, morals, and values. Management should model ethical practice by being transparent in regard to any issues that arise concerning fraud, abuse, or waste. Create clear communication through your policies and procedures. And ensure staff know it's safe to report fraud, abuse, or waste to management or to hotlines. Prepayment and post-billing audits. The North Carolina Division of Medical Assistance Program Integrity Unit, which is in the Behavioral Health Review section, performs preliminary reviews on all cases referred for suspected fraud and abuse by recipients, providers, licensing boards and associations, and local, state, and federal agencies. This process also involves scanning billing for error trends before the billing takes place. With post-payment reviews, this involves an examination of claims payment data, medical record documentation, financial records, administrative research, and application of Medicaid coverage policies. Behavioral health provider reviews may be conducted on or off-site. Self-audits. All providers of mental health, developmental disabilities, and substance abuse services should conduct periodic self-audits. Audits should include pre-billing audits to look for errors before sending them off for payment. In addition, these audits should include a review of consumer records, personnel files, and policies and procedures to ensure compliance with rules, laws, and policies are being met. The requirement for CABAs is that they have a compliance program self-audit policy, and that there's a plan indicating that self-audits will take place and that actions will be taken based on this plan. Quality management projects. Self-auditing is one great way to gather information to formulate quality improvement plans and projects for your agency. As part of your local monitoring reviews, the LME requires agencies to have a quality management committee who analyzes data looking for patterns or trends and identifying opportunities for improving services. As part of your IPRS contract with OPC, each agency is expected to conduct 3 quality improvement projects each year. Agency risk assessment. The steps to take in designing agency risk assessment include putting together a risk assessment team, defining goals and objectives of risk assessment for your agency, putting in order of greatest risk those processes in the organization that need to be assessed, those where fraud, abuse have occurred, or opportunity for fraud is highest. Identify possible fraud schemes distinctive to the process and compare the likelihood against the current controls. Determine the probability of fraud happening. You may use a Likert scale in this process. Assess current internal controls and the need for greater controls. Identify the potential dollar loss. Make a plan to lessen risk for each process that scores high and does not have adequate internal controls in place. Finally, execute the plan and evaluate the results. Lastly, we will discuss reporting fraud and abuse. Most agencies have policies and procedures in place to address the reporting of fraud and abuse. Talking to your supervisor, provided they are not involved in the fraudulent activity, is the best place to start. Also, any staff involved in quality management or human resources should know how to proceed and should know how to talk with you confidentially. If for some reason you are not comfortable reporting the fraudulent activity to someone within your company, the following slides outline other options outside your company. There are several options for calling to report a provider who is committing fraud and abuse. You can call OPC LME and talk with Lynn Hamlet, Quality Management Manager, at 913-4037. You can contact the Division of Medical Assistance by calling 1-800-662-7030. You can call the Medicaid Fraud, Waste, and Program Abuse Tip Line at 1-877-DMA-TIP-1, or the Healthcare Finance Administration Office of Inspector General's Fraud Line at 1-800-HHS-TIPS, or the State Auditor's Waste Line at 1-800-730-TIPS, or you can go online and complete and submit a Medicaid Fraud and Abuse confidential complaint form at this link, www.ncdhhs.gov/DMA/fraud/report-fraud-form.htm. To report recipient fraud and abuse, call your County Department of Social Services or contact the Division of Medical Assistance by calling the Customer Service Center at 1-800-662-7030. Call the Medicaid Fraud, Waste, and Program Abuse Tip Line at 1-877-DMA-TIP-1, or again, complete and submit a Medicaid Fraud and Abuse confidential online complaint form at www.ncdhhs.gov/DMA/fraud-report-fraud-form.htm. It is everyone's responsibility, direct care, consumers, managers, citizens, to understand and follow the laws relevant to fraud and abuse and to report any fraudulent activity. Thank you for your time, and please feel free to call or email me with any questions you may have. My name is Gillian Eberly, and I can be reached at 919-913-4061 or at geberly@opc-mhc.org. Thank you.